Good morning, everybody, and welcome to the first Healthcare World Series event of 2022. Haven't seen you guys since November of last year on our last session at the Healthcare World Festival, and I hope everybody's had an interesting few months as we hopefully are starting to recover from the global pandemic of the last 2 years. For 2022, we will be doing our Healthcare World Series on a monthly basis, and we kick off today with an event talking about Saudi Arabia. Saudi Arabia, probably I think the most interesting healthcare opportunity that we have out there in the world at the moment. My name's Steve Gardner. I'm the Managing Director of Healthcare First. I'll be chairing today's session, which is going to be a little bit different and a little bit interesting. We have with us today from the first cluster in the eastern region of Saudi Arabia, Dr. Ahmed Al-Musayed, who is the Executive Leader for Transformation, Strategy and Business Development, Assistant to the CEO for Clinical Affairs at the Eastern Cluster, and needs very, very big business cards to get all of that onto them. We also have with us from the Saudi side, Neil Hamer, who works on cluster development from the Ministry of Health end of things. They will be the subjects of this morning's debate and conversation. As I say, slightly different format in the respect that we have a fantastic panel of CEOs and high-profile individuals from across the world of global healthcare who will be quizzing Dr. Ahmed and Neil on their development of healthcare in Saudi Arabia. In no particular order, that includes Simon Swift from Methods Analytics, data and analytics company based out of the UK, Ian Chambers from consultancy Linear, Chief Executive Healthcare First Group, primary care provider in the UK, Jyoti Mahan, who is ably assisted by one of her senior clinicians in Patrick Wynn. We have Mona Hayat from Nexus, a digital health startup out of the UK, who we'll hear more about as we go along. Christina Sashaki from Al Tamimi, Isabella Rango from Mott McDonald, and I think hopefully I've covered everybody there. Oh, Mohammed Mustafa from IQVIA, who actually, my excuse is his camera's off, so I can't see him, which is why I forgot him for a moment. Anyway, without any further ado, what I'd like to do is I'd like to turn over to our eminent Saudi representatives, starting with you, Dr. Ahmed, and then on to you, Neil. Quick question from me to kick things off. Can you tell us a little bit about the reorganisation of Saudi healthcare? What is the regionalisation agenda, and what will that mean for international organisations, investors and operators that want to come into the region? Dr. Ahmed, do you want to kick us off?
Well, thank you, Steve. I'm delighted to be here. Thank you very much. Thank you to Healthcare World. I'm delighted to be with the first series this year. Also, special thanks to Christina for bringing me to this group. You know, for the past few years, the Kingdom of Saudi Arabia have been going through a massive transformation through the Vision 2030, and healthcare sectors is basically one of the major sector going through this transformation. Right now, Ministry of Health and the Vision Realization Office are the major driver and representative for this transformation through the National Transformation Program. This massive transformation going across the whole cluster involved not only the reorganization and regionalization of the health delivery system in the country, but also among other aspects like the digital health, the reform along the regulator, along the insurance, the relationship with the private sector and other entities. There is a massive transformation. I'm glad to hear that it's one of the most interesting transformation activities around the world actually is happening in Saudi Arabia, because there is massive support, there is massive leadership from all the way top to bottom to ensure that this activity is going actively toward our objective and to achieve them. Also, I'm glad that we are focusing today on the regionalization and the regionalization, because it's quite interesting that we are doing it here right now in Saudi Arabia. You know, the geography of Saudi Arabia is huge, and also the population of Saudi Arabia almost similar to the population number of largest country in the one of the country in the world, like Canada. So there is a massive activities right now around that. and particular this activity because it's a complex whether are following reorganization or regionalization by geography or by population or by group of healthcare providers like facilities and hospitals. It's quite challenges, but quite interesting at the same time. There is a journey. We are moving from a legacy system toward, as Neil mentioned before, to become an accountable care organization, down the road. All that required a massive amount of activity. But today, we are working very closely with the Health Holding Company, with the Vision Realization Office, with the Ministry of Health to achieve all that goal of the National Transformation Program and Vision 2030.
Thanks, Ahmed. That's a great introduction. Neil, from your point of view, how is this reorganisation working, and what does that mean in terms of opportunities for organisations that want to work in Saudi?
Well, I think we answer the second bit first. The opportunities are huge, it's fair to say. But just to give everybody a flavour of what's going on at a very high level, everything in the country up until now has been run by the ministry, and that's both payment and provision. So we're going through a separation of those two activities. So the ministry will retain regulation authority. The provision of services is being moved out into what we call clusters. So Ahmed is in one of the clusters in the region. The whole country is going to be broken down into approximately 21, what we refer to as clusters. And they're called a cluster until they become an accountable care organisation. So there are going to be 21, possibly 22 of these clusters scattered across the country. They're broken up into regions, and the people you're talking to today are in the eastern region, where we have 3 of those clusters. And Ahmed represents one of the biggest clusters, well, the biggest cluster in the eastern region, based around Dammam area. We've got a north, south, east, centre and west as well. So the similar programs are happening in 21 different geographical areas across the country at the same time. So there's a huge amount of activity. So while my role is an arm's length body from the ministry at the moment, where we support these clusters in their development. And as Ahmed pointed out, it's not just creating accountable care organisations, it's also a massive transformation programme. And this is probably the largest transformation programme anywhere in the world right now. So what you've got happening is two very large activities all happening simultaneously. So you've got things like moving a finance system from a cash to an accrual basis. Those few words sound quite simple, but in reality, that requires a huge amount of work, retraining staff, changing systems. We need to set up a digital infrastructure for the hospital and primary care networks. We need to integrate that. So we have a huge amount of work to do in that area. I think it's important for people to realise where we're coming from within these systems. So if I take an example of that digital example, you're moving out of a situation where probably 2 years ago, nearly everything was on paper records. Not necessarily in the hospitals, but certainly in the primary care sector. And many of the hospitals still are waiting for HIS systems to come in. So there's a lot of groundwork to be done. A lot of it is at base level at this stage. And we have a plan which will take a cluster through a whole series of steps. And this is approximately 5 years from beginning to end. So we're still at what is effectively a stage 2 with the cluster here, which is where they will start to get more responsibility and more accountability as they mature. So our role here is to ensure that we support them in providing capability and capacity. So hopefully that gives you a flavour of what's happening at a very high level. While this is happening, we've got a payer who's been separated off. There's an organisation called PHAP, P-H-A-P, and they're busy working in the background on trying to figure out how the payment mechanism is going to work. And that's a complex enough task to start from scratch. I think there's a lot of countries around the globe which will tell us how not to do it. They're trying to figure out how to do it right. And it's a big challenge. One of our biggest issues is source of data and how much data we've got to look at.
Well, thanks for that, Neil. And I think now that we're talking about the source of data, the fact that the first person I'm going to turn the floor over to is our resident data expert, Simon Swift from Methods Analytics. Simon, question away to our Saudi colleagues.
Thank you very much, Steve, and thank you for the beautiful segue, Neil. So I want to possibly slightly unhelpfully focus in on a particular area of healthcare and use of data in healthcare. You are moving toward an ACO model, and I'm not totally clear on the details of how you're planning on implementing it, but we've worked with a number of ACOs where they're most mature in the US, and the concept that they've used is an organization is given a budget to care for a population, however you define a population, group of people, and then it is up to them to deliver a set of specified healthcare outcomes for that budget, however they wish to do it. Now, I think anybody who spends time thinking about healthcare believes, and if anybody doesn't, please tell me, that the combination of longevity and increasing age, combined with increasing years of life in ill health at the end of life, the rising cost of healthcare activity and finite budgets are, Venn diagrams that do not meet. And this is a problem. My view is that the only way any healthcare system can deal with this problem is to move from being a reactive sickness service to a preventative health service. And the way you do that is with a population health management-led approach. Understand the population, understand what conditions they are at risk of, and understand how you can intervene, mitigate the risk of those conditions. And that's all driven from data, which is what we do. And we do the maths, and we understand the risk predictors, and we understand the interventions that impact on those risk predictors, and then help people put that all in place and monitor and track and all of that. Now, the question that I'm getting to is two parts. Firstly, I think for Neil, any population health management approach has to be tuned to the local population and deliver a specific desired outcome. That might be it's tuned to optimize health gain below the cost. It might be tuned to optimize system efficiency. It might be tuned to optimize cost effectiveness. We're less worried about health outcomes. At a national level, what is the prime purpose of rolling out this enormous endeavor across Saudi Arabia? What are you seeking to achieve?
So, Simon, I think what you described at the beginning was the burning platform that we face as an organisation. That increase in cost of delivering healthcare, the ageing population with multiple comorbidities, all of that is happening, very much happening in Saudi Arabia. What's the driver behind the transformation? It does include what you also described, a move from a reactive system, which was based predominantly around the facilities. So most of the service delivery was focused on either hospitals or healthcare facilities. And so that was a reactive, responsive mechanism, which when the patient arrives at the hospital, they get diagnosed and treated. and it's a curative approach. So what we are aiming for strategically is to make a huge shift away from facility focus to move it to become care around the patient. And that doesn't happen overnight. That takes a significant amount of time to make that change. But the prevention approach is something that is very, very important to us. And to do that, we have to have access to data. And I think it's very important for listeners to realise that we have very limited amounts of data so far. I mean, when you look at population health management, you can look at international benchmarks and standards, and you'll probably be able to work out what happens in other countries is likely to happen here, but it doesn't give us a good steer in terms of what to do locally. So within the individual clusters across the country, what they need to do is to be able to drill down into their local populations to try and identify where are the particular pockets of disease prevalence that they need to deal with, and then tailor-make the services to meet the requirements of the local population. Now that does require us to start collecting data, and we're at a very basic level in collecting that. So again, to give listeners an understanding, probably 12 months ago, we were implementing electronic systems into primary healthcare centres. So in the Eastern Health Cluster, I think it's approximately 120 health centres were all given access to a new system. Now, what you have to do is obviously train people to input into that system. And most of the listeners probably come from countries where actually most of these services are mature or reasonably mature and in existence. So we're in the middle of creating a lot of these services at the same time as we're trying to form accountable care organisations. So it's fine. I know I've got experience from the UK where we took existing mature components and tried to bring those together into integrated care and accountable care systems. And that was difficult enough. And we're trying to do it where they're not mature and where they're going through change. So there are a lot of challenges there, but our biggest challenge is really having enough data to work on. In an ideal world, you'll look at risk segmentation and looking at hospital data, combining it with healthcare data. We're not at that level yet, so we
are actually engaged with a cluster not here today about doing a proof of concept of exactly that, to understand what can be done with the data that exists at the moment. So I might be able to report back to you on that in a few months' time. Thank you for your answer. Really, really helpful, really useful. If I can ask Dr. Ahmed a sort of local version of the same question, that would be kind. Neil's talked about the national programme and national priorities. At a local level for your cluster, is your thinking a little bit more, advanced isn't the right word, but locally tuned? Do you know what your local priorities are? Have you started understanding your population and where you think you need to go first?
Certainly, and thank you, Simon, for this question. I guess the developing an approach toward population health management system is very critical at the moment, because originally it did not exist as a routine practice before. In the past, we have clinical practices that is performed through a number of facilities and passively generate data gathered from all over to collect and to understand our practices and our operation. But today, we have to think differently about our data and how can we compile them with our clinical practices that we are practices today, and we are shifting our clinical practice. In addition to the moving outside of facility practices to become much more population focused and involving not only our sick customer, but also our healthy customers as well, to reach a stage where we can stratify them and focus a number of activity on the high risk one, probably tailor new activities to the less risk one. So I think at the, I wouldn't call at the local level, but I would call at the delivery level, we have acknowledged that population health is a pillar into our reorganization and regionalization and corporatization of our activity. We believe this is something new. We need to pay attention to it. We have to invest in it. We address it as a new paradigm in the clinical practice. So that means that we have a lot to work with our people in order to address it, to acknowledge it, to ensure that they understand it, and become an important element in the shift of delivery of care. Because the data that we are gathering from our population certainly would be a very critical in determining the way we deliver care to them. We have looked into various approaches with the help of Neil from Holdco and others, into how the UK NHSs are doing it, the East Asian. Currently, we are noticing that in North America, that with the more shift from the private practices and the focus on quality and focus on value-based healthcare, there is more concern and more acknowledgement of the enrollment of a catchment population into the cohort of delivery of care, rather than just only relying on the people that are coming to our doors. So practically, in the field, we have acknowledged that would require different collecting our data. So we are working with the Ministry of Health and Holdco into actually improving and optimizing our health information system, and how are we collecting data primarily from the primary care, and then integrating that with the existing health information system that we are having already to our hospital. We have realized that right now we need to start into our population stratification. So we are selecting number of cohorts and number of zones to work around that, along with the national registry system. We have realized that even into our care management system, we need to perhaps shape some of our nursing workforce to focus more on care management, as that would be the major driver and link between data, population, and clinical delivery. And at the system level, we have realized that it is required to look differently into our financial management system. One of the major strengths within the private sector is the revenue cycle management system, and that perhaps in the public sector was not growing much in the past few years or past decades. So we in the public sector start to pay attention to revenue cycle management, our clinical data improvement from within care delivery from hospital and primary care center, refreshing our quality and performance metrics, whether they are hospital-based, primary care-based, or population-based. We are strengthening and developing our relationship that will impact our population health management system with the through the contracting with the payer within the country, which we might consider down the road one of the most influential into the population health management system, the thing that the payer would be looking at through the contracting, the contract mechanism between the payer and the provider here. This actually shaped our relationship with our stakeholders and our partners, whether they are from the private sectors. We are seeking right now to learn more about the TBA and the revenue cycle management from the private sector, and also from our third sector, the NGOs, made us giving more attention than the legacy practice of public health to focus more into prevention and and moving not relying only on the facility-based preventative clinical practices, but also the community-based preventative clinical practices to reach out to more population cohort and calling for the population, for our servant and beneficiaries that they've never come and they don't come to our doorsteps, and basically have giving that the huge attention, realize there will be huge gaps as well into our clinical delivery, especially into our virtual care and remote healthcare management system. Before, when we focused on facility management system, we wait for people to come to our doorsteps. But right now, when we have population dimension and acknowledgement that we have to reach to, we become realizing that how dispersed our bodies are going through our geography, and that made us realize that there is a huge gap in addressing our remote health. So
Thank you. Thank you, Dr. Ahmed.
It's a game changer. Thank you.
Thank you very much, and to Neil as well for your fulsome answers. Steve, over to you.
Thanks, Simon. Yeah, we've got quite a lot to get through, so let's move on quickly. Mohammed, you have some questions, I think, from IQVIA.
Yes. Thank you, Steve, for organizing this session. It's really very useful for everyone. Dr. Ahmed and Neil, it's a pleasure to meet you virtually. First question is to Neil. How would you see the PPP, the public-private partnership, on the cluster, new structure cluster? Is there an opportunity for PPP in the coming years with the new cluster structure?
Yeah, yes, Mohammed, certainly there is, and that's undoubtedly the case. With the referring back to the burning platform scenario, there's increasing costs, and obviously there's been a big blow to the economy over the last 2 years with the impact of COVID. Obviously, there's been pressure on the price of oil, although that's now suddenly catapulted in the opposite direction. But those pressures do mean that capital is under pressure. And one of the directions that the government is taking is to encourage an increase in public-private partnership or PSP partnerships. And those are likely to take place in a number of different areas. And I think we have to also understand the timescale for public-private partnerships and where they work and where they don't. There's a few projects that have already been kicked off. I think if we look at things like long-term care, and if we look at the area of primary healthcare, those are 2 areas where there's quite a lot of potential for public and private partnerships to take place. For those not aware, there is quite a significant private market already in existence in Saudi Arabia in terms of private hospitals available. And one of our challenges, linking back to Simon's question about getting data on patients, is that our issue is we've got a lot of fit, well people out there who've got no great intention of coming in and giving us all their data and information. So to build our sort of population database is a bit of a challenge. Coming back to the public-private partnership, yes, it's a big opportunity. And I think one of the things that it's quite difficult to do for individual clusters is to understand sort of exactly which ones to pursue. You know, if you talk to Ahmed, Dr. Ahmed in a moment, I'm sure he'll highlight some of the clusters' specific areas that they're interested in. But it's having the skill set to be able to pursue those projects and understanding how to do costing of those projects, understanding what the benefits and paybacks are going to be, understanding all the options you've got available, because there's a wide range of the different alternative methodologies that you can apply to PPP.
Thank you very much, Neil. Dr. Ahmed, the question about the cluster. What will be the autonomy in budget and decision making on the cluster side with the new structure of the clusters?
Thank you. Very good question. Well, certainly we are, as a cluster, we are still part of the Ministry of Health. We are part of the health holding company. Autonomy is one of the goals that we are trying to achieve down the road. There is autonomy right now in the operation and the clinical practice, and many our key performance measurement, and being accountable for our outcomes. So there is an autonomy on that. On autonomy, certainly this is something coming, but we have also autonomy on the transformational budget, which basically supporting the private public participation that we are discussing. And as we are part of the national program, there are activity, but also there is a huge interest for us at the cluster level, at the local level in the field. Basically, as mentioned, data management and population health management is certainly of a huge interest to us. This is a new field. We would like to invest in it. We would like to do it better, and also like to groom it up to become a major pillar for our accountable care organization development. Not only that, but also for remote area healthcare, virtual medicine become one of the major interests for us to develop. And then the whole spectrum of patient experience that is ranging from cancer care, rehabilitation, extended care, home care, shifting to primary and ambulatory care, including urgent care, and how can we get specialty care out of hospital walls outside to the community, to the field, to the ambulatory, to the primary care. Also on the prevention and community, and not to forget also, upscaling our services. The private sector right now have gone far into the patient services, but what I'm interested in right now with the BBB or BSP is basically how can we make something tangible on the ground today? Can we work? Can we do a solid contract that is effective and efficient at the national level? And in order for us to reach that, to overcome all the potential challenges on, making that, can we do piloting? Can we do small exercise? Can we do a project in any of these activities in order for us to showcase and to show value that something for the long term could happen?
Thank you very much, Dr. Ahmed.
Thank you, Mohammed. Dr. Ahmed, thanks very much. Let's move on then. Next, Healthcare First. Jyoti, do you want to fire away with your question?
Brilliant. Thank you. So I'm going to, both Patrick and I will take a bit more of a primary care angle, if that's okay. Dr. Ahmed and Neil, you both mentioned primary care and a lot of groundwork that needs doing. From our perspective, so an organisation that has worked through designing primary care at scale and been through some of those challenges, I'd be very keen to understand, when you were considering sort of Vision 2030, what were your design principles and thinking behind your model for primary care, particularly, I guess, in a region where it's quite a new concept and not fully ingrained?
Shall I go first, Dr. Ahmed?
Yes, age and beauty first.
Thank you. So, yeah, a lot of similarities, I think, with other systems in that there's a lot to do in primary care. There are challenges around the workforce and the skill levels. If we're talking about sort of family physicians, and we've got to do quite a bit of work about building up the capabilities of family physicians. We've got facility issues. So many of the facilities are rented, and maintenance may not be the highest of priorities. Some of the facilities are state of the art and are absolutely fantastic. So you've got a huge range of different facilities and different different appearances from the outside. There isn't any particular branding to them. In most cases, there's a ministry logo in there somewhere, but there will be an opportunity for sort of creating a brand within individual clusters. There are different services that we need to move into those primary healthcare facilities as well. Quite often we look at what you can move out of hospital into primary care. So there will be a lot of services that should be able to be delivered at a primary care level. But the idea is not to just recreate more of the same in terms of primary care. Strategically, what we want to do is sort of leapfrog ahead and try and avoid just creating what's already there at the moment. So that's going to involve looking at designer facilities, looking at what services are delivered there. I mean, clearly there are huge steps forwards taking place in diagnostics and how those diagnostics can be conducted. And if we can shift some of the diagnostics from the hospital facilities into primary care closer to home and build those around the patient needs, then that's one of our strategic goals, is to achieve that. Workforce will be a challenge, as it is globally. I mean, not only with, I mentioned family physicians, but also nursing. You know, a lot of the nurses in Saudi Arabia are not able to work up to the same sort of level in terms of their capabilities as they are in other countries. So there is almost an untapped resource here in terms of the nurses. If we are able to increase their capabilities and what they can do within a practice. We still have an issue with people bypassing primary care. So going straight to the emergency room is not uncommon here. And that's something that we need to tackle. One of the other big issues we need to tackle around primary care is perception of it. And the perception being that if they want to get a good service, they're going to have to go to an A&E department. And that's a big challenge for people to take on at a local level. Awareness as well of the individual patients and getting them registered. We probably 12 months ago would have had only maybe 20% of the total population in the country registered. We're working hard to increase that, but when we look at the registration, it's fairly basic. We're not talking about getting people in and running them through a whole half-an-hour health check to identify all their issues. We're just asking them to give us 5 or 6 bits of information, possibly electronic, and that's not necessarily confirmed by a clinician. And that is an area where we have an opportunity. We have a lot of electronic capability within the country. You've got a very high level of utilization of mobile phones in the country, possibly one of the highest in the world. A lot of activity is based around applications, and a lot of those applications are potentially accessible to us in the healthcare world. So most people in the country register with applications and do nearly everything relating to government activities linked to 1 or 2 key applications. So a lot of different issues and challenges in relation to primary healthcare. In addition to that, it's looking at where those health centres are located. Are they always in the right place? Probably not in relation to all of our population. Dr. Ahmed did mention one of the other big challenges we have is rural health. You've got vast areas of the country which are difficult to access, quite a long way from major facilities. So we're looking at trying to understand how do you tackle rural health in a location that's maybe 200 kilometres away from the nearest facility. You've got a lot of tribal and nomadic groups that you'd be able to access. So we have to overcome some of the stigmas and difficulties of persuading them to actually even come into us and talk to us in the first place. So a very wide range of challenges within the primary care sector.
Patrick, did you want to ask a follow-up question for Dr. Ahmed? We've got a couple of minutes before we need to move on.
Yeah, thank you, Steve, and thank you for the opportunity. I think this probably goes to Neil from what you've touched on before. You talked about looking at foreign services, and I'm interested to know what inspiration you've taken from other countries. This is related to primary care, and also what you didn't want to take from other countries.
I think it's probably easier to say what we didn't want to take, because yeah, there are some issues around picking up anything from another country, because you've got to look at what the culture is here to start with, and what the needs are here of the population. And those are very different. We've got a huge proportion of the population here who are either diabetic or potentially diabetic. So that is a major issue for us and a major challenge. In terms of what we didn't want to take as well, we didn't want a fragmented system. So we've looked at a number of systems from, say, New Zealand across to the US to Scandinavian countries. And we've had a number of people giving us advice and guidance. But it's still, at the end of the day, it's got to be down to what the local cluster needs to do based on its own local population. I'm sure Dr. Ahmed will explain to you how they've broken their geographical region up into networks. And those networks are focused around predominantly 2 or 3 hospitals and maybe 20, 30 healthcare centres built in a network. And so it's been very much understand what other people have done, but make sure that it's actually what the locality needs. And that's something that the individual clusters have free rein on doing. They have to create themselves a 2-year and a 5-year plan. And within that plan, there's a number of initiatives which then get a budget allocated for them to deliver.
Thanks for that, Neil. I want to try and rattle through these things fairly quickly. One reason why is because I'm hoping to have about 10 minutes at the end for questions from our audience. And I'm seeing a number of them coming through on my email already. But for those of you that are watching who haven't spotted it yet, on the bottom of your screen, there is a big red button that says ask a question. You click on that, you'll be able to type in your questions for Neil and Dr. Ahmed. But for now, I'd like to move on to Isabel and Mott McDonald. Isabel, what's your question for our Saudi delegation?
Thank you, Dr. Ahmed and Neil. I commend you on your efforts so far, and having been in a similar role in the past and being in the region for 9 years, I very much understand the complexity and the tasks that you have at hand. You've already told us about the challenges with the data, and I'm curious to find in your cluster what have the most difficult and challenging components been in implementing the strategy, both at a cluster level and individual facility, because we know that each individual facility, although they might be close to each other, might have their own challenges. And is the plan to standardize among all of these facilities?
Dr. Ahmed, do you want to take that one?
Sure, thank you for this question. I believe this is touching the core and the heart of the everyday today challenges that we are facing. In the past, I would say in the past few months, years, we have realized that there are challenges coming every day when we work in designing and shaping up, addressing our challenges, and try to understand and gather data and analyze and come up with reasonable design and solutions for our challenges. Honestly, since we started recently putting our hands into the problems, we scoped projects. We selected right people to work with us on the ground, in the field, not in design, but in the field to overcome these challenges. And I can mention a few projects that we have been starting to do, like in workforce planning and redesigning our clinical service lines, and population health management and revenue cycle management and non-clinical shared services, operating activities, and among other digital health projects as well. When we started to do projects with right partners on the ground, we have realized that our challenges and barriers are becoming less and less. We have tremendous amount of support. We have huge support from our leadership. The moment that we start, we are people in the field working with our colleagues from the HOLDCO and others. And how can we put projects on the ground to overcome these? And we focus on the piloting, short term, try to achieve something in the short term, and always aiming for the long term. We started to have realized that. We realized that this is transformation. It is a journey. So we are, we have worked with one of our partners from Europe, and they came to us. When they came to us for a visit, and we visited them in Europe, and they said that what you are trying to achieve is we achieved it in 17 years, and what you are trying to do it in 3 to 5 years. That is really that's a huge burden. However, I think through aggressive business development, focusing on building our capabilities, prioritizing development in the infrastructure, focusing on the pillars like population health management, clinical reform, and financial management, and digital health. These are the major pillars to overcome these challenges, as well as, most importantly, selecting the right partners. I believe that when we have the right partner in the ground, that working with our people, addressing our challenges, understanding our culture, that basically the most important factor in overcoming our challenges and barriers.
Thank you. You mentioned also, one of the challenges also is the staff and the buy-in from the staff, and moving from a resource and staff-centric to a more patient-centric. What have been the challenges with this, and how have you been able to overcome and get the staff on board with all of these changes?
Neil, do you want to start, or want
yeah,
to start?
It's a huge area. I mean, it's all about communication and change, and that's one of the biggest challenges of any transformation program. I think we would probably all be prepared to admit that maybe we should have started it right at the beginning, and we were a bit slow on the uptake. But it's quite difficult to put the message across at the right level, because you need the individual clusters have their own sort of C-suite management, and that sort of local communication needs to be led by them. And they each have their own programs developed to do that. But it is a huge task. When you think across the country, there's 250,000 people within the healthcare sector, and trying to get all of them on board with what's happening. There've been a lot of programs which have been led by clinicians as well. Some of those programs have taken lead people within organizations, not necessarily in the most senior positions, but taking influential people within the organizations and using them to communicate the change. And we've already been doing a lot of model of care change within the country. That actually predates the transformation. So there's been a lot of care pathways that have been adjusted. And as Dr. Ahmed mentioned earlier on, we're also looking at system of care transformation now. So that's a big area where we've done a lot of communication. But taking everybody along with us is a big challenge, and making sure that communication is regular, making sure that everybody buys into the program is something that has to be led from the bottom up and the top down.
I can
Thanks,
add
Neil.
to that. If I can just add
Please, yeah.
to that. I think certainly our workforce is our precious treasure that we are having within our system. Certainly we are facing this with the legacy practices that we have before, that from facility-based to become a community-based and population-based, shifting to digital practices. We are asking them today to shift from a solo practice into integrated care practice. The introduction of virtual medicine, adoption of care, 6 pathways of model of cares, and also the new career and career management and care management. All these are putting a lot of pressure into our workforce. We are trying to make them more appealing to them, incentivize them to go for it. That's why investing greatly in our change management program, building capability in the leadership of new processes, and connecting with Vision 2030 as the inspiration toward all these, toward what we are doing now, is very, very inspiring to them. And inviting new partners. We need a new blood, we need a new air, fresh air into the system, and maximizing our training program. We are investing heavily into training for new skill, new activities. But overall, we are measuring this part of the MOH and health holding company measuring of staff satisfaction, but there is a long way to go for it.
You can have all the digital and data solutions you like, but at the end of the day, healthcare is still a people business. Christina, you're next, please. Your question.
Fantastic. So I've had a bunch of questions and have been just crossing them out as you all have addressed so many things that have been so integral to understanding the transformation that's happening and the future of healthcare in Saudi. And so perhaps maybe my burning question is, just as a law firm, we are often asked about those who are interested in investing in the strategy and helping the clusters, for example, achieve their financial sustainability goals, or helping at the regional level or the national level to help the transformation to succeed. They are looking at, well, what are the opportunities? How do they come in? How do they partner with you? I think then the question is twofold. One is perhaps from Neil's perspective, looking at the wider, perhaps Ministry of Health, public-private partnerships, such as the recent one that came out regarding teleradiology and radiology programs, but then also looking at the cluster specifically from Dr. Ahmed's perspective. Part of your long-term strategy plan is looking at where the private sector either can come in and support the Eastern cluster directly, so building the capacities within the cluster, or perhaps within, for example, the virtual care strategy and creating a spin-off of your home healthcare program that would then become part of a private sector, collaborating then between the government services and the private sector services. So perhaps I seek your input as to what is the thought process or the plan for determining when something might be outsourced, if you will, looking at bringing in a partner either directly within the cluster or as a private sector entrant who would then help fill the gaps that do exist in the cluster, or even when at the national level where the private sector can then look towards helping to meet the or bid on and put in their offers for the public-private partnership. So questions going both ways, and I'll allow either one of you maybe to start off to have your comments on that.
Well, shall I begin at the sort of higher level and try and answer the question about sort of which ones go national? Then Dr. Ahmed can try and respond around the sort of local requirements. When we put together long-term strategic plans, we tend to identify what the key elements are that are missing or required in an area, and what initiatives need to be put into place. And part of that long-term strategic plan over 5 years, we'll identify PSP opportunities. It's a requirement to look at those and try and pull them out. So what we're able to do at a higher level is to say, well, are there some of these that run across the country? And some of those were identified at a national level early on. You didn't really need to talk to individual clusters to identify those. You know, primary healthcare was an obvious example where we knew that there were challenges around sort of rented facilities and out-of-date facilities that needed to be upgraded. There are always hospital opportunities for PSP, but there are also opportunities driven by other factors. In some cases, it's where there is particular capacity overflow. So we don't have sufficient capacity and we need to source that from outside. And it may be available from a private partner. Where there is no capability in existence at the moment, that's another area where you would identify that you might want to go outside for PSP. Where there are technical barriers to entry as well, or cost barriers to entry is another significant driver. So where technology, for example, comes into play, and it's something that, you know, at a high level we would think, well, actually, you know, that's not going to be something that we're going to be able to master in 2 to 3 years. Let's go to somebody who's already spent 25 years and is at the cutting edge of doing this will go to them. So that's another area, and where there are sort of barriers to entry for us, then we might well go to an outside external provider. And if there's a particular burning issue at a national level, so for example, there might be sort of long-term conditions to our blocking facilities across a lot of the clusters in the country, and we've identified an opportunity to free up capacity within the system by going outside of the clusters themselves. So I think that covers sort of most of the areas of opportunity, and then Dr. Ahmed can give you an idea of what's happening down at a local level from his perspective.
Yes, thank you, Christine and Neil. I believe I mentioned before a number of areas that at the service delivery that certainly of a huge interest today to work together. We are working with the national MOH, VRO, private sector participation, hoping one day that we reach to an equation and a long-term contract to define these private sector engagement for a long term. But today, I think there are huge opportunities on the traditional service level agreements and the engagement of the private sector to come and work very closely with the cluster on a number of service delivery. The one I mentioned before around, extended care, virtual care, and others. But also, what I would like to focus on as well, in addition to the traditional service delivery, is our journey today as a cluster to become an accountable care organization. There are a number of activities that are new to us, that it's new to the region, and new to the country, and new to the clinical practice in Saudi Arabia. And saying that, including shifting the accountability from focusing only on the clinical services to become a corporatized organization that is accountable for its finance, for its legal, and for its assets as well. So that dimension that the private sector certainly would need to come closer to help us in that journey. As Ian mentioned, on the building essential capability toward accountable organization around the major three pillars: financial management, population health management, and clinical reform. Most importantly, around integrated care between secondary hospital, primary care center, and around the medical of the tertiary setting, tertiary medical center of the cluster. So, in addition, digital. I wouldn't say we are happy what we are having right now. We are far from happy, but I think digital today is not considered as an enabler, is not a tool that we are plugging into our processes to expedite or accelerate or improve our processes. Digital by itself is a transformation. It's changing our processes, and creating a new field, creating a different way of practicing. So that's another way. That's another field of including, but also not to forget about acquisition of small practices. Can clusters in the near future acquire areas of clear gap? I wouldn't say outsourcing, but acquire existing activities that they are doing it better in the private sector or at the local level, and then become emerging very quickly or very appropriately with the cluster. Various ways nationally at MOH and the VRO are still defining the long-term relationships, but I think even I would encourage the private sector to become a force toward the cluster to develop these solutions together, and this would reflect eventually on a short-term and mid-term contract.
Great, and then maybe just briefly to that end, I know the NCP website will post quite a number of the public-private partnership opportunities coming out from the Ministry of Health. Where would, if anybody, on this call, for example, sees that they have the ultimate solution for the cluster, where would they go to kind of submit their capabilities in terms of being able to support the cluster on any of these key next steps?
Well, certainly today it's national, so it is within the MOH, VRO, the National Transformation Program, the Private Sector Participation Program. Certainly that is the appropriate place for such submissions. But the BSB team within the VRO working very closely with the health holding company as well as with the cluster to groom, to craft, to scope this opportunity and making it happening on the ground. But however, it's not only all the way top down, but as well as sometimes up when we identify a gap, we identify a right partner, and we believe there is an opportunity to develop, a partnership there. We can, all the way up for support and approval.
Fantastic! Thank you both very much. That's really, really exciting. Looking forward to seeing how this all continues to progress forward. Thank you very much.
Thanks, Christina. We're doing quite well time-wise, so we will have 10 minutes for questions from the audience at the end. Just to remind you, there is a red button on your screen just to the right of probably where I'm speaking, which says ask a question. We've got a few in already. We still have room for a few more. But the next question goes to Ian Chambers from Linear.
Thanks very much, Steve, and good afternoon, gentlemen. First of all, congratulations on your groundbreaking success to date and the progress made. I guess notwithstanding those improvements, I was keen to understand what your likely challenges are from your perspective as the organisations progress forward, and particularly looking at the next phase of your evolution. Around key activities such as transformation, operational performance, financial oversight, future strategic direction. And then related to that, how you start to embed those as business as usual, particularly focused on the remit, the responsibility as that expands and you try to get self-sufficiency with what you're trying to do.
That's covered quite a lot of different areas. So
I appreciate it's a big area, but keen to understand the future vision really as you move forward.
Yeah, I mean, one of the biggest challenges of what we're doing is, first of all, the scale of it and the complexity. As I alluded to right at the beginning, it's not only a transformation, it's forming accountable care organisations while we're in the middle of doing a transformation program. That's where the big challenge lies. So the complexity from that comes with all of the different areas which are in the process of change all at the same time. So that puts quite a lot of stress on the system as a whole. And I think one of the challenges, I mean, you were asking about sort of strategic direction. A lot of the strategic direction is already there. I think we know what strategic direction is going to be. It's shifting care to be focused around the patient. It's value-based care, and it's ensuring that we get the best value out of the spend that we can. That we focus on outcomes improvement for the population of Saudi Arabia. That's great on paper, but to do it in reality with the number of different areas we have to concentrate on is a huge challenge. And also bringing together the stakeholders. I think in terms of the next phase of the evolution, what I'd like to see, I think what we'd all like to see is a coming together of all the different stakeholders in this. You know, we have dependencies and our big challenges are around the dependencies. I mean, the clusters depend on us for providing guidance around finance, around clinical governance areas, around how they handle population health management. All of that has to be created, and it's a bit like sort of laying the train track in front of the train, but the train's catching us up. Dr. Ahmed is in one of the lead clusters, but there are 21 odd clusters, of which there are sort of 4 or 5 in the forefront. it's always a challenge just to stay one step ahead. And bearing in mind they've been up and running for a little bit longer than the health holding company organisation has been. So I think it's just the volume and the number of different activities, and the dependencies on other areas are very much in our minds at all times. So the understanding of the payment mechanism in particular will drive a lot of the adjustments to our strategies that we will need to make. And it's a very complex field, working out how you're going to pay for provision of services, and whether you're going to incentivize, say, efficiency savings for the cluster, for them to benefit and share in cost benefit. How do you work out the capitation model, the weighting model? There's a lot of things to think about, especially when you've got a split between public and private sector as well. So I think what I'm saying is it's just a very complex and continually moving beast, which we have to adjust the strategy as we go along to that. We have an underlying strategy which is very, very clear. But there are things that shift in that strategy, particularly around workforce. I think one of the things we've accelerated recently is the movement across of the workforce from regions, ministry, and trying to get them into the clusters. That then puts on further pressure on clusters to look at capability and assessment of that workforce. Does it meet the needs of the cluster's requirements? Then you have to build a training program around that. So it's keeping on top of all of those things which are happening simultaneously. So I think if Dr. Ahmed can give you a view on how that affects them at a local level, that'll give you the complete picture.
Great, thanks Neil, that's really helpful. Dr. Ahmed?
Yes, I think first of all, we become very clear on what we are trying to achieve. We would like to be an accountable care organization. We are a government public provider. We are not a single entity private sector. We are not a single hospital. So we are a group of hospital primary care center. Perhaps some of the cluster have medical city, and we do have a medical city, and covering a wider population with a wider geography. So all that, making us in a quiet situation with a number of challenges. However, we know what we are trying to achieve. We would like to become a model within the world of accountable care organization. We have steps that has been identified by the Ministry of Health and Health Holding Company. We have a number of pathways that we are using toward our goal. We have clear activity or pockets of activities that what we are trying to achieve. However, our biggest challenges today is basically selecting the right partners to work with to achieve that. Selecting the right system around the world, selecting the right model. Perhaps this is quite challenging because we know what we are trying to achieve, but we don't want to do it alone. We would like to do it quickly and safely and appropriately and timely. Understand systems around the world take decades to achieve. We don't want to say we would like to achieve these in a few years, but we would like to achieve them properly, learn from others' lessons from around the world. So selecting right partners is quite challenging for us today in the field. And then developing right businesses, which are the hot spots where we can put our red and yellow flags, where we can say, this is the project that I have to focus on for the next 6 months or 18 months or so for the short term in order to give me the long-term impact. So developing the right businesses is another challenge. We don't have a deep pockets. We have a limited investment. So we would like to use it wisely. Also balancing the quick wins in healthcare and long-term investments. I think that's something that we would like to achieve. Most of the people coming to us, they are looking for a long-term relationship. However, we don't have probably the right mechanism to do that. We are in healthcare. People are waiting for us to show results effectively and immediately. And so we need to balance our investment between having a quick wins and the long-term relationship. And then, as you know, our work with our workforce, mastering change management. How can we master change management with our workforce? We know that we would like to have change management program. We acknowledge its requirements, its priority, its importance, but doing it appropriately, moving outside from classroom implementation of change management into the field, doing it on the ground with the people. After that is basically how can we work with national on the right triple P equations. Certainly it is a national direction, however, it has to be built at a local level. So all the bits and pieces of any triple B equation for the future would require to be at least fit appropriately in the field at the local level. And then one of the biggest challenges is basically joining the rides on shifting to digital. We would like to shift to digital. We would like to make it not as an enabler, but as a major transformation into our businesses and the clinical businesses and the non-clinical businesses. So we would like to have tools that they are cheaper when they are having it right now and quicker to implement than what we are having today in the market, as well as quickly integrated with our existing modules. So I can see that challenges has shifted over the past 3 to 5 years from being is an access and quality of care and value and try to please our customers, and challenges around more of business development, because I think we realize and we know where we are heading.
Thank you
very much for that.
Yeah, thank you both for such comprehensive and candid responses. Much appreciated.
So, the last of our panelists then, saving one of the big topics for last actually, digital healthcare. Mona, do you want to approach that topic with our panel?
Thank you very much, Steve. And thank you, Dr. Ahmed and Neil, for your incredible insights into the future ambitions for healthcare across KSA. We've been talking a lot today. I've been listening to what everyone's been saying about, ACOs and ICSs. And as you know, we're a little bit ahead of the curve, notwithstanding some of the challenges we've had in the UK, but we're certainly familiar with the ICO and the ICS model. You're also aware that there are a number of British health tech companies trying to establish themselves within KSA. I guess I'm asking this question really on behalf of all of us, for everyone who's watching this webinar, for my colleagues on this webinar here today. Is there any appetite for the KSA healthcare system to consider a multi-agency collaboration model akin to the integrated care system within the UK, which is based on seamless digital pathways?
So I think at a very high level, yes, there is an appetite for that. I think it's one of the big question marks at the moment is how do you tackle that from your perspective? I'm not an expert in digital, so I'm not answering on behalf of the country here. But one of the challenges that we do face is, you've got to have systems that report data, feed data, and provide national data and data pools. And we need to get our minds around exactly how that's going to happen. There's a lot of work going on in the background on it at the moment, in the methods we use to collect that data and then subsequently share it back to the people that need it most. We have, as organisations, looked at how we might do that collectively. So in response to your question, Mona, yes, there is an appetite for it. I think the challenge is very much what other countries have faced, in that when you try and put something like this together, we have a digital blueprint that we work to. And that digital blueprint says there's going to be some enterprise national solutions to certain things that everybody's going to take. There will be some national solutions that it's optional for clusters to take if they want to take them up. And then there's the local solutions that they may choose to put in place themselves. how you connect everything together within that, and how you manage that data and the way it moves around the organization is a massive challenge. I mean, I'm guessing you're from the UK, and the UK's experience of trying to do that was not good. Yeah, what we want to do is try and avoid those issues. And I think there's obviously, we need to take account of the fact that there are central systems which are already in place for, I mentioned the applications that are already there already, which we can use to collect data. The appetite is definitely there. I think the other issue in relation to that digitally is if you did do a collective or sort of collective way of tackling the integration of those systems and brought a lot of system providers together, how do you recharge that out? How do you charge for that kind of service? It's incredibly complicated. And to have one person sitting over the top of that, which is what you would really need, and bringing a large number of providers together has its own challenges. So I think it's an ambition, and we know it's an ambition because people have looked at it. I think the complexities of doing it remain so challenging that it would be almost impossible to do something on a full national basis. But as I say, I'm not speaking on behalf of the country here. That's my view on it. Locally, obviously, we have very different challenges with existing systems. Not all hospitals have their systems in place at the moment. How do we deal with rural systems? How do we connect and integrate? And I'll let Dr. Ahmed respond to that.
Yes, thank you, Mona. I think very important, critical actually to realize the existing services and activities, especially in digital, to realize how big the gaps and how much that we require solutions to require for our journey. Starting with the traditional clinical services, certainly there is a massive in the kingdom to install health information systems and to plug in various existing systems and integrate them together to a national unified health information system with an electronic medical record. That is being said for the traditional clinical services, but I mentioned that whether it's from NHS, UK, or others, our journey toward an integrated care require different kind of solutions beyond just the health information system to connect the staff, to connect the teams, and for a better care management that is perhaps outside of any health information system to guide, for example, our care management team. Moving into to become an accountable care organization, there are areas that we have never addressed in the public sector and the delivery sides of healthcare services beyond hospital and primary care system. When I mention about population health management, around data management, about analytics, about perhaps business intelligence and artificial intelligence, around patient risk stratifications and identifications and others. And then we move toward the stage where we might need digital solution to guide our learnings and our capability for financial management around costing, around efficiency, around coding, and around the clinical data improvement, etc. All that require a culture and a group of digital investments that is separate, and perhaps we're not there in the traditional clinical practice. And then when we move to our legal optimization, contracting optimization, and our relationship with payers and regulators, and then our relationship with the new private sectors providers, all that would require a new dimension of digital solution. What I'm trying to say is, apparently, as I know, that NHS and UK have gone so far into the maturity of integrated care and accountable care, and that generated a number of digital solutions either to can help us in Saudi Arabia to develop new businesses that did not exist before in our system, perhaps exist right now in UK, or optimize the connectivity between various departments and various business units that we've never had it before, or to develop solutions that today, like for example, recently we have a digital solution for workforce planning that is basically open source, easily to be optimized, customized, and being adjusted with a very low cost to make it a professional, integrated digital solution to help us our workforce planning, productivity, and capacity planning. So I think there are a vast area of digital solution that we can bring in, apart from the traditional clinical practices. If we come and dig deeper and understand better our existing capability and existing solutions.
Thanks, Dr. Ahmed. So we've got about 9 minutes left. I've got a load of questions from the audience that I'd like to put to you, but I think the one that's coming over more than any other, and about 8 or 9 different iterations of the same question here. If I, as an international organisation, if I'm interested in working in Saudi Arabia, if I'm interested in working with the Eastern Cluster, how do I communicate with you? How do I get in touch? How do I get a conversation going? Dr. Ahmed, do you want to speak to that?
Certainly. You have our contacts. We have our organization. You can reach us or through the Ministry of Health, or through the Health Holding Company, or Vision Realization Office, or the Private Sector Participation Program. There are several ways, either directly or indirectly through the embassy, or directly through to the cluster. What I recommend, usually we do an opening discussion and addressing capabilities and interests from the investor side, and we see if it is that is something matching our needs and gaps.
Brilliant. And Neil, from the central point of view, what's the best way to engage with the Ministry of Health?
Yeah, I think Dr. Ahmed has pinpointed it. There are various different offices. It very much depends on what the activity is. But if you look at the ministry sites, if it's a public sector partnership, for example, there are specific areas that you would go to for that. I think if anybody gets stuck in terms of how to communicate, then we can probably give them some guidance afterwards that we can set up and point them in the right direction, because obviously a lot of different areas that we've covered today, everything from sort of, digital workforce planning right the way through the whole sort of range. And, there are some areas that are very specific and some that you want to channel towards the clusters. So let's have a look at what those inquiries are, and then between us, I think we can probably point them in the right direction. There's a lot of information available on the ministry websites about where to apply. There's quite a lot of information available around the transformation and work and transformation plans as well.
And are there any online repositories of opportunities and things that are being bid for at the moment?
Yeah, so some of the PSB projects get published on a national basis, and there are certain requirements to qualify for those, which people need to get familiar with.
And is that the same from a regional level, Dr. Ahmed?
Yeah, certainly. We are not far from what's going on right now nationally, as well as certain need at the local level, as I mentioned before, especially at the service delivery, especially on the our journey toward the CO, as well as some needs on the digital. But we can drill down when we have close discussion.
And again, I'm trying to summarise as many questions into one as I can. Number of people asking about areas of clinical requirement. So are there particular clinical areas that you're interested in? One particular participant asking there about mental health. Is that a regional question? I don't know.
Certainly, mental health along the spectrum of mental health is not only in the hospitalization of mental health, but also the primary care of mental health and preventative, as well as with the post-acute episodes of mental health. Certainly, there is quite need. Focusing, I think we do have a very solid inpatient services. I think opportunities might come along the ambulatory preventative side and post-acute as well, mental health.
Useful to understand. Specifically from the cluster point of view, I've got one question here about asking about the scale of the cluster. So how, in terms of, can you give an idea of the number of facilities that you've got, the audience, the population that you serve, etc.?
Yeah, right now we are on the east side of the Kingdom of Saudi Arabia. We are covering a huge geography, coming all the way from the border of Kuwait, all the way to the border of United Arab Emirates, through our trip to Riyadh. It's a huge geography covering around 3.4 million population, with a quite mixed insurance around there. We do have a private sector provider. We do have non-Ministry of Health provider, including the military and the university educational system. There is a quite mixed provider over there. We do have within the cluster, we do have around 20 hospitals, more than 120 primary care center, and a medical city that is serving us to work around oncology. We have a medical center for cardiology. We do have a separate institute for mental health, and we have a separate institute for women's and children. So that's basically roughly an overview of the cluster.
No, useful to understand. Another question here about payers and how the payer system works. I know, Neil, you said that this is still in development. Are you looking to aim towards an insurance-led payer system, or will it be a mix of government pay and insurance?
So the answer to that is it will be insurance-led. So there's an organisation called PHAP, which listeners can look up, PHAP. They're developing the payment mechanism, and we're waiting to find out exactly how that's going to operate. We're running on shadow budgets for the time being, which means we're using the existing ministry finance mechanism to pay the individual clusters. And we're expecting to run like that for a couple of years yet. And once we know a bit more about exactly how that mechanism is going to work, then things will become clearer for us all, I think. But what we do know is that the clusters will be tasked with looking at how to get the most out of those budgets, efficiency improvements. So if anybody's got ideas on how that can be achieved, then I'm sure Dr. Ahmed and the rest of the team there would be very keen to speak to them.
Fantastic. So I think that's we've got a couple of minutes to go. So I think really I'd just like to sort of tie up what we've heard today. I think it's been a really fascinating debate. It's been a really fascinating conversation. Thanks to our panel of questioners. I think the format's actually worked quite well. Everybody's got the chance to pose their questions, but it wouldn't have worked without Dr. Ahmed and Neil, and I appreciate very much the work that you guys have done. You've had to impart an awful lot of information and answer an awful lot of difficult questions, so really well done, and thank you so much for being involved and for being, I think, grilled lightly on both sides by both our panel and our audience. I think what is clear is that that we were what I was hearing, what I was starting to get a sense of when I was out at Arab Health in January is correct, and that is that Saudi is definitely the place to go in terms of opportunities, certainly in the next year or two in the Middle East, and a great place to start. It's very much, there is an openness and an interest in understanding what kind of services and knowledge can be gleaned for around the rest of the world. And I think that there is anybody that's looking at the Middle East at this particular point in time definitely needs to be thinking about Saudi Arabia. The scale of opportunity alone is huge. From a Healthcare World point of view, we'll be looking at this throughout the year. This is just the first of a series of Healthcare World sessions looking at Saudi Arabia. Our next one in a couple of months will be on digital and data, specifically in Saudi Arabia, a topic that we've covered to some degree today. We're also going to be doing an infrastructure session later on in the year, and we're hoping to go and visit Dr. Ahmed in the Eastern Cluster in November of this year. More details of that we hope to be able to publish fairly soon. It just remains for me to thank all of my panelists. So thank you to Mona from Nexus, Christina from Altamimi, Patrick and Jyoti from Healthcare First, Mohammed from IQVIA, Isabel from Mott MacDonald, Ian from Linear, and of course Simon from Methods Analytics. But finally, thanks again, and thank you so much, Dr. Ahmed Al-Masayed. Thank you, Neil Hamer, and thank you to you, the audience, for attending. We hope to see you on the next Healthcare World Series event next month. Thanks very much. Goodbye.